Alright, this is part 4 for the cardiopulmonary procedures for Clinical 2, and we are starting with the cardiac dysrhythmias. So the first thing we're going to talk about is a normal ECG, which consists of that P wave, QRS complex, and then the T wave. This repeats in a regular pattern, so there's no reason for us to worry about an abnormality. So this is typically called a normal sinus rhythm, and it is interpreted as within normal limits. So the waves and the intervals, the segments, and the cardiac rate, those all fall within a normal range. So what is going to decide what is a normal range? So we have to look at some of these terms that describe that. So we have a normal heart rate. Remember, that's going to be between 60 and 100 beats per minute. We have sinus bradycardia. Remember, brady is slow, so this is going to be below the 60 beats per minute. And then tachycardia is going to be above the 100 beats per minute. So if we have a normal rhythm but our rate is elevated, we would have sinus bradycardia or tachycardia if it's too high or too low, but a normal rhythm. So what about these cardiac dysrhythmias? Let's talk about them, because those are the bad ones. Those are the ones that look abnormal. And those are the ones that are going to catch your eye and you're going to be like, uh-oh, this is not right, this is not good, we've got to do something to fix this. So this is an abnormal electrical activity in the heart causing an irregular heartbeat. Most of them are harmless. Some of them can be serious, like they're actually life-threatening. And it's going to blow your mind when we talk about who is going to be most likely the one to have one of these dysrhythmias, because guess what? It's going to be those folks that are asymptomatic. Okay, so let's look at the categories of these dysrhythmias. You've got the ones with extra beats, the abnormal rhythm, which is that dysrhythmia, and then your abnormal rate. Okay. All right, so we have the dysrhythmias. So we have atrial premature contraction, proximal atrial tachycardia, atrial flutter, atrial fibrillation, premature ventricular contraction, ventricular tachycardia, and the most deadly, the ventricular fibrillation. Okay, so what is so specific about these rhythms? Well, let's look at the proximal supraventricular tachycardia. Okay, so the description of that says that it's actually abbreviated PSVT. And what we're going to see is that the heart rate with this dysrhythmia falls between 150 to 250 beats per minute. So with this, you have a quick onset and then a quick termination. So it starts and it stops very, very quickly. Now, the sudden increase in that rate, it happens in short bursts, and it only lasts for a few seconds, in which the rate would come back to that normal before the proximal supraventricular occurred. So what we see when we look at that picture of what this particular rhythm looks like, here's what you're going to see. Those cycles are very, very close together. Okay, so they're tight. All right, you still have the normal PQRST, but everything is tight. Okay, so what kind of symptoms is the patient going to have? So we're going to have where the patient is saying, I've got a sudden pounding or fluttering in my chest, and I'm weak when I have it. They have breathlessness and severe or acute apprehension. Remember, acute is going to be right now, short-lived. So that follows right with the description of the PSVT, because remember, it starts quickly and it ends quickly. All right, sometimes those patients that have PSVT, they even have syncopal episodes. So that's one of the things we need to remember about PSVT. The heart rate's between 150 to 250. The rhythm, it happens very suddenly, and then it ends suddenly. All right, those patients have sudden pounding and fluttering of their chest and weakness, breathlessness, and a lot of acute apprehension. The patient even could have a syncopal episode. Then we have PAC, which is the premature atrial contraction, and this is where we see that a beat comes before the next normal beat is due. So the most distinguishing thing that we're going to see when we're looking at that on a piece of paper is that the P wave of the premature beat, it actually has a different shape from the P wave of the normal beat. With this one, it'll have a normal QRS complex and a normal T wave. But remember, the P wave is going to be different. All right, so what is the clinical significance here? Why are we so concerned? Well, this is going to happen in healthy individuals, but it's also associated with the intake of stimulants like caffeine and tobacco. So this could happen to any of us. A lot of us consume caffeine, whether it be chocolate or sodas or coffee, whatever it may be. We like our caffeine. So be careful with that. You might have PACs. All right, let me go back to that PSVT, and I failed to give you the significance, the clinical significance. But for the PSVT, it is one of the most common rhythm disorders because it happens in healthy individuals, again, with no underlying health problems like heart disease, and they have normal hearts. So you can see this in any patient. Okay, so moving on to atrial flutter. Atrial flutter, think about a butterfly. This one is a rapid, regular fluttering of the atrium. Remember, the atrium's the top chambers of the heart, and the heart rate's going to fall between 250 and 350 beats per minute. Now, if you think about that, that is really, really fast. 250 to 350 beats per minute. Y'all, a normal heart rate is 60 to 100. Now, think about how fast that is. So, the biggest things you see here, there's going to be more than one P wave that precedes the QRS complex. So remember, precedes means it comes before, and that P wave is going to appear like it looks kind of like a sawtooth spike between those QRS complexes. Okay, so that looks kind of weird. Now, what else you might remember is that the QRS complexes of atrial flutter, they kind of are normal, but the T wave is one that's normally lost. So the P wave looks different and it's sometimes lost. Now, what's the clinical significance? Okay, it's normally found with patients with underlying heart problems. So this one, of course, we would expect from some of our patients that have coronary artery disease, mitral valve prolapse, maybe as having an acute myocardial infarction, the heart attack, chronic lung diseases, even hypertensive heart disease. So this is common with those patients. Now let's look at atrial fibrillation. Remember, fibrillation, if you recall that from terminology, remember that's just a quivering. It's an unproductive rhythm that just basically shakes. So with atrial fibrillation, we typically call that V-Fib. The P waves have no definite pattern or shape. Okay, so they're irregular, wavy undulations that come between that QRS complex. Then the QRS complex and V-Fib, they are actually normal, but they don't have a definite pattern. It's kind of weird, but look at this rate of heart contraction. 400 to 600 times per minute. My heavens. 400 to 600 times per minute. That's 4 to 6 times faster than what it should be at the upper level. So this is crazy. A lot of patients feel very bad with this. This can happen with our healthy individuals again, but they can have some with, or have the atrial fibrillation with some of our cardiac patients with heart disease. It can be caused by emotional stress, excessive alcohol consumption, or even vomiting. So with your patients that are actually younger than 50 years old, they actually have atrial fib that's common with those congenital heart diseases and rheumatic fevers that have the mitral valve involvement. So the ones that are older than 50 that have AFib, this is typically caused from other diseases that cause maybe ischemia or hypertrophy of the atria, like coronary artery disease, mitral valve disease, or maybe even a hypertensive disease. Okay, then let's move into the premature ventricular contraction, which we say is a PVC. Now the PVC is like that child that just can't sit still. It's got to be jumping in and doing something before everybody else. So it's the most common rhythm disturbance, and what we see here is that the PVC is the beat that comes early in the cycle. It is not preceded by a P wave. It has a wide and distorted QRS complex, and it has a T wave opposite in the direction of the R wave of the QRS complex. So it stands out, and it's just one little thing. It's like that one kid that's just waiting to pop out and say surprise, but they can't wait for everybody else. So this one, yeah, it just jumps right out at you when you see it. So what's the clinical significance? It's seen in normal individuals again, in all age groups, but here's what it's caused from: anxiety, smoking, caffeine, alcohol, certain types of medications that have things like epinephrine in them. So anybody can have this. Anybody. So it happens a lot with your patients that have heart disease, things like hypertensive heart disease, ischemic heart disease, digitalis toxicity. So a lot of people that have mitral valve prolapse, these are the ones that we're going to see the PVCs with. Okay. All right, V-Tach, or ventricular tachycardia. This is a series of 3 or more consecutive premature ventricular contractions. Remember, ventricular means the bottom part of the heart. And this is happening at a rate of about 150 to 300 beats per minute. Okay, so it's going to last a short time, and it very well could pop up and last for a long period of time. So it's kind of bizarre, but here's the thing. Your QRS complex is widened, and there's no P waves present. So in my opinion, it looks kind of like somebody has just taken a pen and go up and down in a kind of a smooth rhythm, and almost like a lie detector test, if you've ever seen one of those, where the distance between the going up and down is tight. So it's not real bad scribble scrabble, but it's just like woo-dee-doo, moving around the pencil. So it just looks like an easy scribble scrabble, if you will. Now, this could be sustained ventricular. This could be sustained ventricular tachycardia. Is a life-threatening dysrhythmia because the rapid ventricular rate, what it's going to do, it's going to prevent the heart from filling properly. So this is going to affect the cardiac output, meaning the blood flow as well, and it often makes this one thing happen, and it's really, really important. If you see V-Tach, most often it's always going to lead to V-Fib, which is ventricular fibrillation. Okay, and we don't want to see that one. That's the deadly one. Okay, now with ventricular tachycardia, it's usually seen with patients in acute or chronic heart disease. It runs, the V-Tach is indicated with coronary artery disease, and it also is a complication of a myocardial infarction. So again, we don't want to see that ventricular tachycardia because we're probably fixing to see V-Fib. All right? So again, ventricular fibrillation, V-Fib. This is the most serious dysrhythmia. I like to say the most deadly. The ventricles do not beat in a coordinated manner, so it's just quivering again. So this is not going to release that blood and pump it from one end of the heart to the next and in and out so we can get it throughout the body. So what tends to happen here is it's a irregular, chaotic undulations of the baseline. So you're just seeing a lot of sawtooth, scraggly looking scribbles on the actual EKG sheet. So there's no recognizable P waves. The QRS complexes or T waves, they're all in an irregular line of jagged spikes. So if you've ever looked at an old hand saw, it kind of looks like that. But what happens here, this makes a big problem for us. There's no effective ventricular pumping action. So that messes up the circulation. Alright, so it's the most deadly and it needs to be treated immediately or it can lead to sudden death. So, what is the clinical significance for V-Fib? Well, it's the most common of the ventricular, the most common part of ventricular fibrillation is that it appears during an acute myocardial infarction. Okay? So I'm going to end that here with all of the dysrhythmias.